लास्ट क्लास में गाइस अपन ने फिमोरल हर्निया कंप्लीट कर लिया था। 2 मिनट रिवाइज कर लेते हैं जो जो पढ़ा था उसको। उसके बाद में अपन सो सेप्सिस चालू करेंगे, ठीक है। नहीं होगा भाई 98 यार, सॉरी। इट्स 100 and 100 ओनली। हाँ तो गाइस, लेट्स सी द थिंग्स। First of all, we are having the lower limb, right? So the basics of the lower limb should be in your mind. What are they? This is my which bone, guys? This is ilium, ischium, and pubis. Between ilium and ischium, we are having sacroiliac joint. Above ilium, we are having iliac crest. Ending of the ilium is known as ASIS, that is anterior superior iliac spine. Inside, we are having inner lip. Outside, we are having outer lip. All these things, ASIS, inner lip, outer lip, all these things are very important, guys. Why? Because from ASIS we are having inguinal ligament, which is going to go where? Which is going to go to the pubic tubercle. This is what, guys? This is your inguinal ligament, right? Then on iliac crest, this inner lip is nothing of use, but the outer lip is very useful, guys. Why? Because on outer lip you are going to find a origin, and that origin is of what, guys? That origin is of fascia lata. Then between two pubic tubercles, we are having what, guys? We are having this symphysis. This is known as pubic symphysis, right? Pubic symphysis is your FMG exam question. It is which type of cartilage? Anyone can tell me? Yes, guys, it is secondary cartilage. Antheroid is more common in males. Gynecoid is more common in females. Anthropoid is rare, but it always finds in males as well and in females. And platypoid is only and only rare presentation of your platypoid. Okay, guys. Now, see something important. So from ASIS till pubic tubercle, I am having inguinal ligament. Midpoint of inguinal ligament, the middle of inguinal ligament is known as midpoint of inguinal ligament. Just above that, what you are going to find? Just above that, you are going to find deep inguinal ring. And this deep inguinal ring is again your FMG exam question group, because if from deep inguinal ring you are having the intestines coming outside, and these intestines are coming from deep inguinal ring then to the superficial ring then scrotum. This is a type of hernia, and the name of hernia is what, guys? Name of hernia is indirect inguinal hernia. Then we are having one imaginary line from ASIS till pubic symphysis. We are having this blue color dotted imaginary line. Midpoint of that imaginary line is known as mid-inguinal point. This mid-inguinal point is important. Why? Because just below this mid-inguinal point, if you will palpate, you will find the femoral artery, and this femoral artery is important for ABG, angiography, angioplasty, and stenting of the heart. Then we have discussed about fascia lata, guys. Fascia lata is what? Fascia lata is a dense fibrous layer which is covering the outer side of the pelvis as well as the thigh. From where it is coming out, guys? It is coming out, the origin of this is what, guys? The origin of this is ASIS and the outer lip of iliac crest. What about the incision, guys? Incision is on the lateral condyle of the tibia, and where on the lateral condyle? It is the Gerdy's tubercle, guys. The Gerdy's tubercle. Great. See, guys, what I am telling about fascia lata, it is coming from ASIS. It is running parallel to the inguinal ligament until the pubic tubercle. Then it will go down forward and towards the lateral side. Until here, it will be smooth. After this, it will get irregular or rough, and it will attach where? It will attach to the outer lip of the iliac crest. Then After connecting towards outer lip of the iliac crest, guys, what will happen? It will shut down like this, and it will shut down where? To the thigh as well as to pelvic area. Guys, try to understand that this fascial atta is going to give how many modifications? This fascial atta is going to give me two different modifications. What are the names of this modification, guys? First of all, it is your saphenous opening, and second of all, it is what, guys? It is the compartment of the thighs. In saphenous opening, what you should remember, this is having two parts: superficial stratum, deep stratum, and what else? In at the content of this, guys. So content is what? Content is your great saphenous vein. Then you are having lymph nodes. What are the name of those lymph nodes? The lymph nodes are Cloquet lymph nodes. Then you are having one nerve. Name of that nerve is medial femoral cutaneous nerve. Medial femoral cutaneous nerve. Then you are having two arteries. What are these arteries, guys? Superficial external pudendal artery and superficial epigastric artery. All these things are important here. Great saphenous vein is the longest vein of the human. It is coming from where? It is coming and attached to medial malleolus. Great. And one more thing, guys. Between your femoral ring and the saphenous opening, there is a space, and this space is known as femoral canal. What about the femoral ring, guys? This femoral ring is having four different boundaries. Upper boundary is of inguinal ligament. Lateral boundary is of what, guys? Sorry, medial boundary is of lacunar ligament. Lower boundary is of Cooper's ligament, also known as pectineal's ligament. And the lateral boundary is of thin fibrous septum. And this septum is attaching to what, guys? This septum is attaching to your femoral vein. Your femoral vein. Done. Now let's talk about femoral hernia, guys. The entry point of your femoral hernia will be femoral ring, and the exit point will be your saphenous opening. What is happening in the femoral hernia? Any intestine which is coming inside your femoral ring. Why it is coming inside? Because this femoral canal got weak. In which person this femoral canal will got weak, guys? Especially it will get weak in females. Which kind of females? There are two different kinds of female. One is elder female, another one is multiparous female. Anyone who can tell me what is multiparous, guys? What is multiparous? So multiparous is a female who can give birth, or who has already given birth more than two babies. So she has already been with two deliveries, right? That kind of female is known as multiparous. That the hernia can be divided into two parts. One is your simple hernia, another one is your complicated hernia. What are the difference, guys? So in OPD, whenever you will see the patient, you are going to discuss to, or you are going to tell, or you are going to order that person is what, guys? You are going to order that person to cough. When the person is coughing, and if intestines which are there in that swelling are coming out, it is what, guys? It is your cough impulse positive. And in complicated hernia, this cough impulse either can be positive or can be negative. Negative more than positive will be happen, right? Second is what, guys? Second is your reducibility. Is it reducible or not? So how you are going to check it? You are going to put the finger in the swelling, and if that swelling is decreasing, it is reducible, right? So this reducible is for what, guys? This reducible is for your simple hernia, and if it is not reducing, it is your complicated hernia. Last thing which we want to discuss in the femoral hernia is, guys, the surgeries. So there are two surgeries for the simple hernia and one surgery is for the complicated hernia. In simple hernia, we can do either the Lockwood surgery or the Lotheson surgery, which is low inguinal approach or the inguinal approach. But complicated hernia can be done by the McCavity cavity surgery. In this, we are having what? We are having above inguinal vertical approach. Great. Now let's, before discussing the psoas sepsis, we have to discuss some important things, guys. That is about the psoas major muscle and your iliacus muscle. That is about your psoas major muscle and iliacus muscle. For that, let's study about first of all the psoas major muscle, guys. What about psoas major muscle you should know? So this psoas major muscle or psoas major muscle, whatever you want to say, this is coming out from where, guys? This is coming out from or originating from transverse process, guys. Transverse process of which vertebras? Transverse process of T12 to L5 vertebras, right? That is your origin. What about insertion? Insertion is lesser trochanter of femur. This psoas major muscle, it goes down and mix with another muscle. And the name of another muscle is what, guys? The name of another muscle is your iliacus muscle. And if they mix with each other, they're gonna make one muscle, and the name of that muscle is iliopsoas muscle. Nerve supply is important, guys. The supply which is the nerve which is supplying to your psoas muscle and the nerve which is supplying to your iliacus muscle, both are important. So the psoas muscle is supplied by what, guys? It is supplied by directly the spinal nerves. Which spinal nerves? Anterior rami of the spinal nerves. And this is from root value L1 to L3. What about iliacus? It is supplied by femoral nerve and the root value is L2 to L4. Done, guys? Any issues until now? I hope no. Let's talk about psoas sepsis, guys. Psoas sepsis is what? Psoas sepsis is a rare but very serious condition in which accumulation of painful pus inside where, guys? In your psoas major muscle. Done. So painful accumulation of the pus inside the psoas major muscle is going to be what? Is going to be psoas sepsis, right? This pain will locate where, guys? This pain will locate. Location of this pain is what? Location of this pain will be lower lumbar region. Location of this pain which is happening due to the source abscess, it is due to the pus which is accumulating inside the source happening to lower lumbar of region. Few important things which you should know about source abscess is it is going to happen on the right side more than on the left side. It will be secondary more than primary. And if it is happening on the both side, if it is bilateral, it will be around 3% in the total population. Done. Now, what is primary source abscess? In what all situations we are going to say source abscess that it is the primary one? The situations are if it is due to some blood contagion. How it can happen? Suppose you are having any kind of blood infection, so you are having some bacteria inside your blood, and all of us know that blood will be supplied to each and every part of the body, right? So this blood will go to your source muscle also. Once it is going to the source muscle, the bacteria which are inside the blood, they will stay in the source muscle, and they will start making the pus inside the source muscle, because in source muscle we are having lots of protein, right? Due to which what will happen, this pus will make abscess inside it, and this abscess will have pain in your lower lumbar region, right? It can spread due to any occult situation also, occult or hidden sources. So if a person who doesn't know about their conditions, we call them hidden conditions, right? For example, what guys? For example, if a person is having diabetes mellitus type 2, if a person is having AIDS, if a person is going with kidney failure, if a person is having decrease in immunity, or if a person is IV drug abuse, in all these conditions you can have primary source sepsis. How this decrease in immunity can happen, guys? Decrease in immunity can happen due to high use of steroids. Due to high use of steroids. Secondary is what, guys? Secondary is due to spread of infection from GI tract. So if a person is having some problem in some pathology in GI tract, then also this can happen, right? What all are the conditions you should know? So total there are 5 conditions. First of them is what, guys? Let's discuss it. It is appendicitis. Then the person can have diverticulitis. A person can have Crohn's disease. A person can have perforated colon cancer. Or a person can have spondylodiscitis. All these are the condition in which a person, or all these are the infections. From these infections, bacteria can travel to the source muscle, and then the person can have what? Then the person can have source abscess, right? Great. If someone is asking you what is the most common secondary infection which will happen to the source abscess, the answer is gastrointestinal infection. If someone is asking you the examples of the gastrointestinal legs, it is this: appendicitis, diverticulitis, Crohn's disease, perforated colon cancer. In all these conditions, you can have infection. Now, suppose you are sitting in the OPD, right? And a person is coming to you, and person will tell some signs and symptoms about XYZ disease. So how you will see all these things, guys? So the signs and symptoms which a person can tell you in source sepsis, it will be what, guys? So first of all, the person is going to say, Dr. Saab, I am having source muscle spasm. A person can tell you about back pain also. Fever also, because it is infection na. So in infection, fever is most common. Patient can have weight loss also. Source muscle spasm, back pain, fever, weight loss, as well as abdominal flank pain. All these are the things a person can say. What you will do? You will do diagnosis. For diagnosis, first of all, if any person is coming with the abdominal pain, the first thing you are going to do is what, guys? You are going to palpate the person. Here also you are going to do. So in diagnosis, the first thing which you are going to do, it is what, guys? It is physical diagnosis. So in physical examination, you are going to do first thing, that is palpate the patient. At the time of palpation, you are going to find mass. You are going to find some extra mass. Where you are going to find it, guys? You are going to find this mass at or in your inguinal region, as well as in your groin area. So these are the two places where you can find this person is having mass. What you are going to do with this person, guys? Now you are going to have some kind of maneuvers. Out of them, there are two important maneuvers which you should know. What are these two important maneuvers, guys? First one is your source extension test. What you are going to do in source extension test? Total, you are having two steps in here. Step one is what, guys? In step one, you will tell the person to sleep. Once the person is sleeping, what you are going to do with this person, guys? So once this person is sleeping, you are going to tell him to put his right leg up. Once this person is doing his right leg up, what will happen? Suppose this is the leg now. So this person will going to feel the pain on this side, guys, right side, right? That is the first thing. What about the second step, guys? Second step is, so you are going to ask the person on which side this person is having pain. Suppose this person is having pain on the right side, you are going to make him sleep laterally, and the lower surface will be the left surface. So now person is sleeping laterally. His left hand will be below the head, his right hand on his abdomen, and then this person will sleep like this, right? So above one is the right leg, below one is the left leg. What we are going to do, we are again going to tell the person to lift his right leg laterally. So once this person is lifting his right leg laterally, He will again feel the pain on the same position. He will again feel the pain on same position. Done, guys. These are two steps which are known as source extension test. What's next, sir? So the next is your resisted thigh flexion test. Second one is what, guys? Second one is resisted thigh flexion test. In this resisted thigh flexion test, what you are going to do, you are again going to make him sleep, right? And now you will tell him to flex his right leg if he is having pain in right leg, and flex his left thigh if he is having pain in left thigh. Here I am having, or here this patient is having pain in right thigh. So what this patient is going to do, guys, this patient is going to, what you are going to tell to this person, you are going to tell to this person that push your knee towards the chest. Push your knee towards the chest. And you as a doctor will put your hand here, and you are going to force on the opposite direction. This is what, guys, this is doctor's hand. So doctor's hand is going to push on the another side, and this person is going to push like this. When they will do this kind of action, what will happen? Again, the pain will happen. Done, guys. After doing this much, you will get to know one thing, or you should know one thing until now, that psoas abscess is going to have a triad. So psoas abscess is having what, guys? Abscess is having a triad. We call it triad of psoas abscess. What does it mean, guys? It means that if any person is having this kind of triad in his body, I am 88% sure that person is going to have the psoas abscess. How I will get 100% sure, guys? I will get 100% sure with the help of this radiological analysis, which we are going to discuss in few minutes. Let's discuss about the triad of the psoas abscess. The triad of the psoas abscess is having three important things. Of course, it is an abscess, it is an infection, so the patient is going to have what, guys? The patient is going to have the fever, right? Secondly, the patient is going to have back pain due to this infection. And the last one is what, guys? Last one, at the time of palpation, you have palpable mass. This palpable mass either can be on which area, guys? Either can be on the groin area or can be on the flank area. Palpable mass at the side of groin as well as on the flank. After acknowledging this triad, you are going to transfer to the radiological analysis. And what are the radiological analysis you are going to do, guys? So the investigation of choice is what, guys? Investigation of choice here is your CT scan, which will give you accuracy of 80 to 100%. As well as you will tell the person to have blood test also. In blood test, you are going to see two things. First is CBC, another one is culture. The reports of CBC will come within 24 hours, and the culture reports takes time. It takes around 7 to 8 days to come. If it is a bacterial infection, this CBC is going to show one thing, and this thing is known as left shift. So if there is any kind of left shift shown in your CBC, it is what, guys? It is bacterial infection, and what kind of bacteria is attacking, that we will know after 7 to 8 days in culture. Done, guys? Now let's see this here. So these are the abdominal CT scan which we have done. Can you see this green color thing, guys? This is your psoas muscle. This is your psoas muscle. here, and in lateral also. Can you see this here? This is your source muscle. So once you have seen the source muscle, now try to understand this, guys, that this source muscle should be like this, right? But it got thickened. Can you see this thick area here? It got thick. As well as if you will see this thick area, you are having this black color shade inside here. So this black color shade is what, guys? This is your abscess. Okay. Here also, see the size of the source muscle got big, and now you can see here what? Now you can see here the abscess inside the source muscle. Great. After confirming the diagnosis, after knowing everything, the last thing which you can do here is what, guys? Last thing which you can do here is the treatment. And what is the treatment, guys? Treatment of any kind of this, any of this kind of what you say, abscess. The best treatment is to drain the abscess. Get rid of this abscess. How you can get rid of this abscess? You can get rid of this abscess from surgery. Total, there are three different surgeries which you should know here. What are these surgeries, guys? The first one is the open surgery. What we are doing there, we are giving a cut just in front of the source muscle. We are going to remove all the layers of the abdomen. Then we will find the source muscle and we are going to drain the source muscle like this. That is your first thing. Second is what, guys? This is your intercutaneous drainage with the help of CT scan. So in CT scan, you will find this abscess, right? So this is my source muscle. Here I am having the abscess. What I am going to do, I am going to pierce the needle and I will take care of the all organs which are present here so that no one will get injured. And then I will go enter into the source muscle. I will enter inside the abscess. Once I will enter inside the abscess, what I will do, I will put one catheter inside it. Once I will put the catheter, I will connect this catheter with the big syringe, around 50 ml syringe. And what I am going to do, I am going to make vacuum in this syringe. Once vacuum will be here, what will happen? This abscess will start coming inside the injection. Okay. Next is what, guys? Next is laparoscopic source abscess drainage. In laparoscopic source abscess drainage, you are going to give three small cuts. One will be the bigger cut, which will be around the umbilicus. Another one will be 5 cut. Another third one will also be the 5 cut. So this big 10 cut is for the camera, and other two are your working ports. So from here you are going to put the instruments and you are going to find the source muscle, and then you will take all the source abscess from which you will take this source abscess. The name of the instrument is suction tube. Done, guys. Until then, what will happen? Until then, your blood culture report will come. So once the blood culture, कहाँ पे गया blood culture? हाँ. So once your blood culture report will come, what will happen, guys? You can easily find out the names of the bacteria which are present here. So what are the bacteria which you will find, guys? So the most common pathogen in any abscess in your body, most common pathogen in any abscess, it is what, guys? It is your Staph aureus. It is Staph aureus. This Staph aureus can be treated by antibiotic. Name of this antibiotic is what, guys? It is penicillin. Or it can be treated by penicillin as well as its derivatives. Can you tell me in the chat, guys, what are the penicillin derivatives you know? So it's amoxicillin as well as you can give ampicillin also if you have heard about ampicillin. Both of them are penicillin derivatives. But what happens sometimes, guys? Sometimes you can have the antibiotic resistance also, right? And this antibiotic resistance will do what, guys? Even if you will give penicillin to this staph aureus, this staph aureus is not going to react, or it is not going to kill with this, guys. So what will happen in that, when we will check it on the culture, this staph aureus, you will see it is antibiotic resistant staph aureus. The name of this staph aureus is what, guys? It is your MRSA, MRSA, methicillin resistant staph aureus. Methicillin resistant staph aureus. This methicillin resistant staph aureus can be treated by one and only one drug, and the name of that drug is what, guys? Name of that drug is vancomycin. What else can do all these things, guys? So if a person is having this kind of abscess, but this person is HIV positive person, in this kind of person, the infection will be happen by what, guys? This infection will be happen by Mycobacterium tuberculosis. In Mycobacterium tuberculosis, you are going to use anti-TB drugs. So there is something new in this anti-TB drugs. Please try to study it, guys, because now FMG exam will ask this question so much. They have changed the regime of TB drugs. Okay, as for latest update. Then you are having the secondary, guys. So for secondary infections, it is GI infections, and the most common bacteria which will do this GI infection, it is what, guys? It is your E. coli, Enterobacter coli. It is E. coli. So once you are done with the psoas abscess, let's come to the obturator hernia. In obturator hernia, we are going to make the diagram, guys, first. So what is the diagram here? Of course, we are going to have ASIS, then superior pubic ramus, then pubic tubercle, and below we are going to have ileum. After ileum, we are having ischium and pubis bone, right? In between, we are going to have what? In between, we are going to have this foramen. Name of this foramen is obturator foramen, right? Let's label it. This is what, guys? This is your ASIS. This one is your pubic tubercle, and the hole inside here, this hole, guys, this is what? This is your obturator foramen. In obturator foramen, guys, we are having one canal. Name of this canal is what, guys? Name of this canal is your obturator canal. In obturator canal, three things are going to come out: obturator artery, obturator vein, and obturator nerve. All these three things are going to come out from obturator canal. Rest whole foramen is covered by a very thin fibrous layer, and this thin fibrous layer is known as what, guys? This thin fibrous layer is known as your obturator membrane. This fibrous layer is what, guys? This fibrous layer is your obturator membrane. What about this, guys? This is your obturator canal. And from this canal, your artery, vein, and nerve is passing. This is your artery, vein, and nerve. What will happen here, guys? Try to understand. So, first of all, the person, those who are going to have this kind of problem, this person's age will be more than 60 years of age. So, these persons are what, guys? These persons are very, very elder persons. In this kind of persons, what will happen? The fat which is present in front of their obturator canal, this fat will get dissolved, or this fat will go away because of this age. And then what will happen because of that? The intestines which are coming here, if they will have enough amount of abdominal pressure, this intestines will try to come out from your abdominal canal. This is known as obturator hernia. Entry and exit is same, that is your obturator canal. One more important thing, very important thing which you should know is what, guys? Girls versus boys ratio. So girls versus boys ratio is what, guys? Girls versus boys ratio is 6 is to 1. So 6 is to 1. Out of every 6 female, there will be one. Out of, like, if there are total 7 patients, 6 will be female and 1 will be male. Done, guys? Now, let's write about this, guys. So at this age, there will be excessive loss in the fatty tissue. And this fatty issue is present where, guys? This fatty issue is present at femoral canal. Femoral बोल रहा हूँ, obturator canal. And how you will find it out, guys? You will find it out with the swelling which is present under the Cooper's ligament, or another name is pectineal ligament. So any swelling which you can see just under the Cooper's ligament or the pectineal ligament, this is known as what, guys? This is known as the obturator hernia, right? One more thing which you should know here is what, guys? So the patient is having this kind of hernia, right? So this hernia is having one sac also around it. And this sac, okay, let me write only. So we are having what, guys? We are going to have the hernial sac. And this sac is going to what, guys? This sac is going to lead obturator nerve compression. Are you getting me, guys? So if my obturator nerve is getting compressed, this person will going to have pain even if it is a simple hernia, first of all. Second of all, if this person is going to have the pain, this person will come as soon as possible to the doctor. So this kind of hernia, if this is happening to a person, that person will arrive with a lots of pain in the obturator nerve. How you are going to find this, guys? So for that, you are going to examine this patient, and on examination, you are going to do again some maneuvers. What are the names of the maneuvers, guys? First is Hauschip-Romberg sign. And the second is Hannington Kiff sign. Hauschip Romberg sign and Hannington Kiff sign. In Hauschip Romberg sign, you are going to do what, guys? In Hauschip Romberg sign, you are going to abduct and medially rotate. What will happen? Shooting pain to the nerve will happen. So you are going to do the abduction and the medial rotation as seen here, guys. So you have abducted the leg, and then you are going to medially rotate the leg. Once you will medially rotate it, the person is going to have shooting pain. Done, guys? Where this shooting pain will happen, guys? This shooting pain will happen at the medial side of the thigh, the place where your obturator nerve is supplying. Done. Then we are having Hannington Kniff sign. In Hannington Kniff sign, you are going to do what, guys? So you will make a person sit like this, and after making a person sit like this, you are going to first of all check his patellar reflex. So when you will do the patellar reflex, his leg will come up, right? That is normal patellar reflex. After checking the patellar reflex, you are going to hammer this person on the medial side of the leg, or sorry, medial side of the knee. Once you will do this, what will happen? This knee will come towards the another knee. So this knee will come near to the another knee. So for checking where you are going to tap, you are going to tap over medial epicondyle of femur, or you can tap where, guys? Or you can tap on the medial condyle of tibia. So on this side you can tap. Okay, let me make it together. So these are the two places where I can tap to a person. When I will tap it, what will happen? The leg will come near to another leg. The leg will come near to another leg. The distance between these two knees will get decreased. That's how you are going to check Hannington Kniff sign. Of course, femoral canal is very small. So again, femoral. Of course, the obturator canal is very slow. Because of that, the patient will have high risk of obstruction as well as strangulation. Either in the obstruction or in the strangulation, what you are going to do, you are going to perform a surgery, and the name of the surgery is laparotomy. In laparotomy, what you are going to do, so in laparotomy can be done by two different processes. First one is transabdominal preperitoneal repair, and one is total extraperitoneal repair. Which one you are going to prefer? You are going to prefer transabdominal preperitoneum repair. Transabdominal preperitoneal repair. And this one, which is not very useful, is total extraperitoneal repair. Done, guys? Can you see this clinical question? So, what will be your examination, guys, here? What should you think? Only four students are there, they can answer. I'm coming in few seconds, guys. Okay, I'm going to washroom. Until then, I will wait for your answer. अच्छा, तीनों ने आंसर कर दिया जो तीन बच्चे देख रहे हैं. It's Hauschip-Romberg sign. Great. One more thing, guys. Try to understand this. You have studied what, guys? You have studied that this person is going to have what all are the persons those who are going to have this, guys? So the females are more than the males, right? Females are very more than the males. So there is some extra thing which you should know for this, guys. What is that extra thing? Extra thing is, in females you can examine this obturator hernia with per vaginal examination also. So if you are doing per vaginal examination in this kind of patients, especially in females, of course, you will find positive tenderness as well as positive swelling in the region of obturator foramen. Now, what are all the investigations you can do? The investigations you can do for obturator hernia, first of them is USG, ultrasound, or you can do CT abdomen. So in USG, if you can see here, so this here is my obturator foramen, and from obturator foramen one intestine sac is coming out, right? This is obturator hernia here. Then on this side, if you will see the arrow marked area, it is your obturator hernia. Somewhere here I am having the obturator foramen, and from this intestine is coming out here, right? See guys, here. This is my obturator hernia, right? Now, one very important thing guys, if you are going to be a surgeon, you should know this thing guys, and the thing is myopectineal orifice of Frouchard. So what is this guys? The patient is going to have the surgery, and the point of view of this surgery is what guys? On the point of view of the surgery is, we are going to put a mesh in this surgery, right? We are going to put the mesh on this surgery, and the place where we are going to put this mesh is the given name is what guys? It is myopectineal orifice of Frouchard. Why it is important guys? It is important because from this place, if you are putting the mesh, you are going to treat three different hernias. It can be either femoral hernia, or can be either inguinal hernia, or obturator hernia. So if I'm putting mesh here, I'm closing all the gaps. Okay, so try to understand it guys. There is a place where if the surgeon put the mesh or place the mesh, they are going to prevent all below hernias. What are these hernias guys? It's your, of course, obturator hernia, femoral hernia, and inguinal hernia. Obturator hernia, femoral hernia, and inguinal hernia. These are my three different hernias which we should know. All these three hernias will be covered if I am putting this myopectineal orifice of Frouchard place. If I am putting the mesh in this place, right? Now, let's draw the diagram to understand where this location is situated. Okay. For that, we are going to make first of all ASIS, superior pubic ramus, pubic tubercle. Below we are having ischium and pubic bone. In between we are having what? In between we are having our favorite obturator hernia. Obturator foramen, sorry. From our early knowledge, we know that from ASIS till pubic tubercle, it is my inguinal ligament. And then this inguinal ligament is going to go from medial side to the lateral side, and it will make what? It will make lacunar ligament. Then it will run on the superior pubic ramus to make Cooper's ligament, also known as pectineal ligament, and this Cooper's ligament is going to attach to my inguinal ligament, that is the thin fibrous septum. This thin fibrous septum is also attached with one thing. This thing is what, guys? My femoral vein. Then to the lateral side of the femoral vein, or just below the mid inguinal point, I am having femoral artery. Right? After this femoral artery, on the lateral side, we have studied that there will be a muscle. What is the name of this muscle, guys? So the name of this muscle is iliopsoas muscle, right? My iliacus muscle and psoas muscle, they both are coming together and mixing with each other. This is iliopsoas muscle. I hope everything is clear until now. The next thing which I am going to have here is what, guys? It is going to have my pubic symphysis, right? Then again I am going to have here pubic tubercle and all these things. Try to understand, guys, just about the pubic symphysis. Here I am going to have one muscle. And what is the name of this muscle, guys? Name of this muscle is rectus abdominis muscle. The name of this muscle is rectus abdominis muscle, right? And from my ASIS till rectus abdominis muscle, I am going to have this one thing, and this thing is going to cover my full area. Here. And this is known as what, guys? This is known as conjoint tendon. Now, let's see the place which I'm going to highlight. This is the place where I'm going to put my mesh. Okay. Let's take the sky blue color highlighter. So I am going to stitch the mesh here. I'm going to stitch the mesh here until here, and then I will join it with the conjoint tendon. So this is the place where I'm going to put the mesh. And this place is known as what? This place is known as myopectineal orifice of Frouchard. What are the boundaries of this Frouchard, guys? Boundaries are lateral boundaries, iliopsoas muscle, as you can see here. So on the lateral side, I have done stitches on iliopsoas muscle. What is the medial boundary, guys? Medial boundary is lateral border of rectus abdominis, lateral border of rectus abdominis. What about the superior boundary, guys? Superior boundary is my conjoint tendon. It is conjoint tendon. If you will see, to be precise, it is searching fibers of conjoint tendon. What about the inferior boundary? Inferior boundary is same as your Cooper's ligament. So suppose, guys, if I'm putting it here like this mesh, my deep inguinal ring is closed, right? My femoral ring is closed, as well as the area from where intestine can go to the obturator canal. This is also closed. So from putting this mesh at one place, I am preserving this patient from three different types of hernia, that is obturator, femoral, and inguinal hernia. I hope this thing is clear, guys. This is very important thing, and I am going to definitely ask one question about this thing, either this thing or obturator hernia. Okay. Now, what about acetabulum, guys? Acetabulum, it is large cup shaped cavity where your femoral head is going to articulate. This is made up of all three bones. What are these three bones, guys? Ilium, ischium, and pubis. Right? What is important here? Important is this cartilage. So what we are going to study at birth, all these bones, they are joined by the hyaline cartilage, and then from birth till puberty. So first of all, before puberty, it is a Y-shaped cartilage. The name of this Y-shaped cartilage is what, guys? It is tri-radiant cartilage. It is very important. Again, guys, I will ask you this question. What is this, guys? It is tri-radiant cartilage. What next, guys? Next is after puberty, it will get mature and completely ossified. So after puberty, it will get mature, and the shape of this cartilage will now become horseshoe shaped cartilage. It will look like this. So this horseshoe shaped cartilage is present where? It is present inside your acetabulum. Great. Last topic for today, that is the congenital hip dysplasia. Can you see here, guys? So this person or this baby is having congenital defect in which the head of the femur is dislocated from acetabulum. It is not normal, but you will find this kind of condition usually in the babies at the time of birth. So what is congenital hip dysplasia? It is a condition where the bones in hip, they don't fit together completely. This kind of person is having what, guys? This kind of condition is a genetic condition. And what are the treatment, guys? Treatment is this babies have to wear a brace which will help femur to articulate inside acetabulum. After this person can have physiotherapy. If this kind of thing is having no result, then last option is surgery for hip dysplasia. That's all. बच्चे मैसेज करके डिलीट क्यों कर रहे हैं? Hello guys, that's all for today. I hope you liked it. सोते हैं, कल सबको ड्यूटी जाना है या फिर क्लास जाना है ना? Just let me know if anything you want to ask for like next 5-10 minutes. We are together. बातें शातें करते हैं, फिर आराम से सोएंगे. कोई प्रॉब्लम आई हो इन सारे टॉपिक्स में, कोई भी चीज़ पूछनी हो तो पूछ. Anything you want me to improve. इतनी रात तक टिके हो, एक दिल तो बनता है तुम्हारे लिए. यू फॉर बीइंग विद मी. आई गेस देयर इज नथिंग. बच्चे वीडियो चालू करके सो चुके हैं. feel हो रहा है. इट्स ओके गाइस, एडिट कर देंगे अपन इसको बाद में, कोई दिक्कत नहीं. हैव अ नाइस टाइम. पीस आउट.